Hello everyone, I'm one of the dentists that's been working in the Children's Dental Service, which is just on the other side of the hospital for the last couple of years. I'm just going to give you a brief overview of kind of what we do as a department and then kind of focus in on one of the programmes that we've been working on quite a lot this year. So, okay. Right, just a little bit. I just really enjoy our waiting room. So there you go. We do try and make coming to the dentist. I know it's not everybody's favourite thing, but we try really hard as a department to welcome children and their families in and make it a really kind of safe environment where we get a lot of positive work done, but also leave them, kind of happy to go into the world of private practice as an adult and not have any sort of issues about the dentist, because we all hear them. Oh, when I was younger, and the school dentist did this and that. We really have worked so hard to change the reputation of that kind of old image, and I think we're doing a really good job of it. So, brilliant. What we do kind of as a service is see children through one of two ways. The first one is, remember what my clickies are, is just obviously we get around 500 referrals a year, and that is kind of a representation of us at the hospital, and we get those from a variety of people who we generally regarded as maybe more high risk, and that is based on a lot of evidence that's kind of coming from the UK over the last kind of several decades, where they've been doing annual and decade-long children's dental services, and they find that a lot of the decay can be concentrated in areas where there's kind of lower socioeconomic kind of backgrounds, whether it's based on kind of free school meals and things like that. And also we know that children with special needs have additional needs, and we do tend to see a little bit more problems in those. So for those children, we see for their routine checkups every 6 months and do treatment as required. We do also see a lot of people from the dentists, which are referred if they have any sort of decay at all. We'll see them for one course of treatment and then send them on their way. We do reception year and year 5 screening in schools to pick up anybody that doesn't go to the dentist. Again, they come in for one course of treatment and then back to the private dentists. And we also do a lot of work in the community. I think over the last couple of years we've averaged around kind of 30 visits, and that may be kind of young mum groups or kind of toddler groups, scouts, and brownies. Anyone that will have us, basically, we're more than happy to go and discuss a little bit about kind of oral hygiene and that sort of thing. So that's kind of where it all comes from, and this is what we tend to see. Obviously, decay in the baby teeth, it can come on really quickly. The enamel is very thin, and so you end up with problems. It literally in between the course of a checkup, even in times if the conditions aren't right. So, and a lot of the time, we may, if I just kind of do the old handshake, which is what I do to my if we cover this up from the top, everything looks absolutely fine. This is what we tend to see in the kind of 3, 4, 5-year-olds. They're not old enough really to have any x-rays, but there actually can be significant dental problems hiding underneath it, and that's really why we need to kind of get in early with the prevention to kind of stop this thing from happening, because by the time that's been sitting there for a couple of years, you're going to end up with a big abscess, which is very difficult to manage in young children. Unfortunately, we do between 90 and 100 general anaesthetic treatments each year, and a lot of that is just decay, basically. Sometimes we do get trauma and things like that, but the vast majority of it is just teeth that are unrestorable in uncooperative children, which is such a shame. Because we do know that aside from if you're rather unlucky and you are born, for example, with teeth that haven't got very strong enamel, the vast majority of things are actually preventable, and all of this is completely evidence-based, going back years and years, and we can advise people what to do at home. And obviously, as part of a dentist, we have a couple of things that we can do to minimise decay, such as sealing adult teeth in young children kind of as soon as they erupt generally, and we have a really, really high rate of doing this in the department. We make sure that we do kind of vital signs each year, see how many children we're putting fluoride varnish on, which should be done every 6 months or more often if they're high risk, and how many children we're doing fluoride varnishes, fissure sealants on. And we're seeing that we've had a massive increase in all of these preventative measures. So we really do feel like we are getting the message across that prevention obviously is better than management for everybody involved. But we are still ending up with problems. A lot of changes within the department have been going on, and that can be kind of in between what we actually do to the children when they come in for decay, kind of moving away from fillings and going towards the stainless steel crowns. I know they're not everybody's favourite, but actually they're a really reliable way of restoring teeth in children. They last a lot longer than fillings do in many cases, and we can do them on much younger children as well. And kind of moving away from complex root canal treatment and towards timely extractions of their adult teeth just before the one behind comes in, so you kind of get rid of a bad tooth and a fresh one emerges. And so, it's always about kind of looking at what the best evidence is. Are we doing the best thing, the most up-to-date thing for our children? And I think that's definitely something the department at the minute is doing really well. There we go, and just some evidence of success. So we do screening. This is basically just the decay rate of children from, even in just 5 years, the number of actual children we're seeing who have decay has gone down from almost 1 in 4 of them to less than 10%, which I think is fantastic. The surveys, which is what we do when we do the kind of 5-year-olds and the reception year children, this one's looking at the actual number of teeth that are treated. So in the past, only around a third of the cavities were treated, whereas now we can actually see there's a lot more fillings in there, which can be seen as a negative thing, but it actually means that they've gone to the dentist and had the filling done. So now around two-thirds of teeth that have been affected by decay actually have something in them. And we are getting much less toothache. So there you go, that's the annual toothache number that we get. So in just 3 years, we've knocked off around 100 emergency appointments, which makes our life so much easier. And I think it is because we are getting to children younger, and also we're changing the way that we're restoring. So for example, less fillings, more crowns. I do think it makes a difference. So less repeat treatments, and we've also got a really good working environment to be in as well. So there you go, that is just to demonstrate the kind of the number of teeth that are kind of with decay in the year 5 children had been going down year and year and year. So when we're looking at, okay, all this good stuff, but we know we can be doing more. We do a 3.5-year check, which everybody is invited to, with their immunisations and their eyes, and we still pick up decay at that point. 3.5 years, some of the teeth have only been in the mouth 6 months, 12 months, and they've already got cavities in them. What can we do to stop it? They're really difficult age group to manage. So we've got all these things going on, and we know that there are many things which actually prevent adults from going, because at the end of the day, they're the ones responsible for taking the children. And we were kind of thinking of a way to get some advice out there, but kind of sidestepping all of those barriers, and just getting children more involved in brushing their teeth, and actually finding a way of getting fluoride, which is what keeps our teeth nice and strong and healthy, to the children without having to have them come to us. And so what we wanted to do in this little picture is add in another setting, and this is actually what we're focusing on in our preschool toothbrushing programme. So we looked across the channel for some inspiration, and Scotland, Wales and England, they've all got these national oral health programmes where they're involving schools from a very young age and doing toothbrushing at least once a day, sometimes twice a day in high-risk areas, and basically using that as kind of a platform to also engage the families in oral health advice, diet advice, more fluoride varnish applications at school, for example. It's basically just a really good way of kind of getting the message out there, bringing it to the forefront of people's minds rather than kind of in the background, which is so easy to do in life, obviously, just to put off going for your checkup for whatever reason. But we wanted it to be a little bit more further forward in people's minds. And so what we did in 2013 was we started Guernsey Super Smiles. The team actually won a bursary for £2,000, which enabled them to buy in a load of equipment, so toothbrushes and the buses that hold them, and also get a computer system which allows us to monitor the children, so how many children with decay at the beginning and how many at the end, so we can kind of have some support for the programme. And by the end of 2013 they were doing 1 normal preschool, 2 charity-based preschools and a primary school, so targeting about 170 children, which is great. And we found that children were not brushing their teeth twice a day, for sure. 1 child didn't brush their teeth ever, and about a quarter of them were not brushing them twice a day on a kind of everyday basis. And not many of them had been to the dentist either, and half the children had never been, and most of them went for a checkup. It was just they'd gone kind of with their family. So these are the things that we really wanted to change, but as with all good things, they always come to an end. The money ran out. The charity preschools, the whole system changed. They kind of devolved into other preschools, and so we weren't really sure what to do, which is when luckily we had got in touch with the kind of early years in education department, and they had cottoned on to the fact that we're doing this programme and wanted to basically bring some new life into it, see if we can expand it across the island a little bit. So this was a couple of years later. We figured out how many preschools would want to be involved and a rough cost estimate. So if we look at this, I think that's 500 for, but yeah, £5,000 for the 2 years is how much we estimated that we'd need, and that is to cover around 8 to 10 preschool settings with once a day toothbrushing, which isn't really that much when you think about it. The average cost of a single general anaesthetic is what, like about £350, so on the scheme of it, it's fairly cost effective, and this is backed up by the Child Smile, which is a Scottish programme, which estimates that the resources were freed up within 3 years from the initial costs. So we thought this was a really good thing to be doing. We just needed a little bit of funding. So we reached out to various charities, and luckily we got a couple of organisations that were really interested. So big thank you for all the guys that donated money to us. We managed to get the full £5,000 from just these kind of charities and associations alone, and so that is what we did. October of last year we rolled it out into 8 preschool settings, and since then we've got a couple more, 2 more I believe, 2 more in the works as of last week, and also pretty much the whole of La Rondon is now doing daily toothbrushing. So it's been really, really successful. We've got well over 320 students who are participating, and it's had a really, really good effect, especially on the children who then come to their 3.5 year clinic with absolutely pristine teeth, and they talk about, you know, toothbrushing kind of with their friends. They tell me what colour toothbrush they've got. They're just a little bit more engaged than they were before, so which is really fantastic. We did actually go and screen every child that was involved, and I have to say that their mouths were genuinely clean. Like, it was actually a relief to see that what they had been doing is making an impact. We've had several preschools come forward and ask that we go in and do activities with the children. They've been really keen to tell us that they're kind of getting on board with healthy eating as well, which is obviously another really important thing about oral health. So all in all, it is going extremely well. So there you go. Just a little picture. We actually had some media. Oh, hang on, I've gone off it. There we go. We actually had we went to one of the preschool settings, and the Channel News, I think, and BBC Guernsey came and did the pictures. These children went through their brushing routine like 4 times in a row, so everybody could get pictures. They were absolutely fantastic. It was a little bit hit and miss in places, but towards the end. But no, they were absolutely fantastic. They've all got different songs to do it to, or these little videos. Like, that's what we need to get it to be easier for, you know, children at home, because I mean, it's fine me telling parents that their children need to brush their teeth twice a day. I don't have any children yet, you know. I appreciate getting a 3-year-old to brush their teeth twice a day. It's not always that easy. Anything you can do to make them want to do it, I think, is well worth the time and effort. So there you go. We've got a couple of quotes from either parents, or mine is a pig. I'm hoping that one's one of the children. That little stick. I don't know. So yeah, all really, really positive feedback. Many of the settings were worried that it would take too much time, that, you know, they've got their own kind of targets to hit, and not a single one of them has had any problems. You know, we basically let them go. They're running it themselves, and because of that, that's why when we went back in a couple of weeks ago to see if anyone else wanted to go, we've got further people who want to do it. So really, really happy with that, and that's why we kind of want to keep going. We need some more money. Now, the £5,000 is still going strong, but that's only for 2 years. We really want to roll this out into other areas, and basically offer it to anybody that's interested, and keep it going for longer than 2 years, because that's really what you need to do. You need to get it as kind of running in the background in order to see any sort of effect. So, you know, the numbers are good at the minute, but it's only time will tell if it's worth it. So yeah.
Anyone else experiencing dental hygiene guilt right now? Yeah, show of hands. Yeah, thanks for that. So, Recovery and Wellbeing Service. I'm Graham Dewan. I'm an occupational therapist, which basically means I weave baskets for a living. For anyone who's done anything about occupational therapy, the wholesale production of woven products. I work at the Recovery and Wellbeing Service, which is over there. We used to be over there at the Cattell Hospital. Anyone know the Cattell Hospital? Big old scary building. Yes, nice new building. Very nice. So a lot of the work that we've done has been because of that move. What is the recovery model? Anyone know? No, great, fantastic, I can talk about it. Well, I Googled some images about recovery, and I came up with these, thank you Google images. So it's a pathway, it's about decisions, about old ways of doing things, new ways of doing things. I like this one, this is about sort of growth, really, in some ways. It's not about computer recovery. I discovered that was one of the images that got thrown up. Didn't know about that. It's not about vehicle recovery either, which is what I first thought recovery was about. And I've no idea why shoes came up at all when I Googled it. Anyone know? No, bizarre. But so it is. It's about pathways, it's about decisions, it's about growth. Recovery is based on the idea of self-determination and self-management. Within physical healthcare settings, it's called reablement. People heard that kind of phrase? It's kind of, it emphasises the importance of hope in sustaining motivation, in supporting expectations of an individually fulfilled life. So that can go quite deep. At the heart of it is a set of values about somebody's right to build a meaningful life for themselves with or without the continuing presence of mental health problems. So one of the most fundamental changes that we made was when we sat down with someone that presented to our services. In the time before this, we'd say, what's your problem? Yeah, like you'd say, what's your problem? They'd say depression or anxiety, bipolar affective disorder, schizophrenia, psychosis, all these problems. Now we say, what do you want to be able to do? Completely different kind of question. And actually, if you ask somebody what their problem is, it focuses in on negative stuff, and your ability to be able to create ideas in your head is reduced. If you ask people what they want to do, suddenly people are a lot more creative and they think of different things. It takes a lot of time to encourage people through these things. We use a tool called the Recovery Star. It's a multifaceted 10-item outcome measure, and it's a key working tool, so it's an individual tool to sit down with somebody, and it's been widely adopted by service providers in the UK. I went to Jersey about 8 years ago to look at their mental health services. They were using it. I nicked it. I brought it over here, and then slowly we as a service have been using it more and more. We've bought the license. We've used it. It values service users' perspectives and enables empowerment and choice. It supports recovery and social inclusion, and it's developed, interestingly, with service users. The Recovery Star was actually it was developed through the homeless population in UK. They wanted a tool that would speak about their individual problems and about where they want to go. And it was, obviously there's quite a lot of crossover between people that are homeless and people with some mental health issues. And so the Mental Health Service Users Forum took this tool and thought, actually, let's make this more applicable specifically for mental health issues. And now there's a whole variety of stars. There's one specifically for substance misuse, for well-being. There's a children's one. There's all sorts. So in its development of this tool, this outcome measure, there was a lot of service user involvement. There it is. Looks nice, doesn't it? It looks nice because it's simple and easy to understand. These are basically 1 to 10. And we ask people to sort of say roughly where they are on a scale of 1 to 10 on this, with 1 being, I'm stuck, I don't even want to talk about it, I'm pulling the duvet over my head, I'm not even going to get out of bed and talk to you about it, that's it. Well, it's still a mark. Or 10, I'm completely fine. It's a very holistic tool, this outcome measure. It talks about these different areas, 10 different areas. It's a journey. And we say to people, you can go up and down this journey, this travel between stuck, leave me alone, to accepting help, to wanting somebody else to sort things out for me, to believing that you can make a difference, to learning how to do this, to self-reliance and managing without the help of services. So I quite like these pictures. They're quite good, aren't they? You can really get and we show this to people, and people kind of get it. It's easy to do. So on a scale of 1 to 10, we say, where are you? self-reliant, see ya. So that's when we were discharged back out. Generally, we find people are sort of operating around here. When they're here, they're on the ward, generally, or stuck at home. When they come to the recovery and wellbeing service, they might be on the ward and just starting to poke their head out of the ward a little bit, maybe coming over to us to use our computer suite or something like this. So we'd sit down with them, we would go through each of these one by one, and it takes quite a while. I mean, it really does. And service users have fed back to us that they really value that, because you're really addressing each individual area bit by bit. Again, without focusing on what their problems are. You'd actually start focusing on the bits that they're really good at. Because if you start working on the bits that people are really good at, and they do more of that, well, actually that affects the other areas. If you've got good social networks, then you're more likely to look after your physical health. Yeah. If you've got good living skills and you're able to think about the practical sides of where you live, and you're doing that, you want to do more of that, you get better and better at that, then it's likely that you improve social networks and you're going to be moving towards work and things like this. So we find that the more you focus on positive things, it affects other areas as well. I could just read through all of that, but that's going to be so dull for you guys. So I understand that these presentations can be accessed and you can read sort of later on. So who are we? So we're not at the Cat Hill Hospital. That's not a picture of the Cat Hill Hospital. This is our building, which we like very much. I like this little bouncy thing. It's great, isn't it? So that's our corridor. Interestingly, and I know this is going to sound weird, one of the best things about us moving from the Cat Hill to here were these. I'm going to move out of shot now, James, all right? These there. The doors getting into the department. I'll tell you why. It's because of social inclusion. This is going to sound weird. So in the old day centre, people could just rock up, go into the centre, make themselves a cup of tea or coffee, use our washing machine, do the washing, do the drying, sit at the table, go outside and smoke, hang out, maybe do a group or two, do a bit of art, do a bit of chatting here, there and everywhere, and just hang out all day. Is that social inclusion? Is it? Kind of is, kind of isn't. Because actually what people do, they are coming out, they're mixing with each other, but they weren't really moving out. We as a staff group have to really work hard in trying to get people to make that next step. So when I remember the meeting really well, when they're planning the design of the building, one of the last meetings, they said, so these doors then, Graham, are they going to be just open? People could just come in and like hang out? I said, well, no, actually, we need them locked. We need them closed. That's what I mean. It sounds a bit weird, doesn't it? But it's about treatment. When you go into the Oberlins, you'll see that there's a nice big open reception, there's Beacons Cafe, people can hang out, that could be a social area. People would sit and watch the world go by. When they come in through their doors, they're coming in to work as part of treatment. They're coming in because they've been referred for a specific thing, they're going to work on a specific goal or target that they've chosen, that we're working collaboratively with. We do risk assessments, we work individually with people. So they're coming in for a specific session. They're not just coming in to kind of hide from the world. So it's a big change. So we've got some lovely group rooms. We've got an IT suite. That's one of our most frequently used rooms. It's a nice environment. So what do? Yes, we stick plasters on heads. That's exactly what we do. We work in secondary mental health care, so that basically means that if somebody goes to their GP, the GP screens, use screening tools, maybe treat with antidepressants or other medications. If that gets too complicated, if people are not responding so much, we've also got the primary care mental health and wellbeing service, so they might do short courses of CBT-based work or counselling-based therapy. If that kind of doesn't work, then it's secondary mental health care. So we see people in acute stages of mental distress, but also people with very enduring presentations as well. No matter what you throw at somebody, They've got really complicated histories and very, very difficult to kind of work with. RAWS, Recovery and Wellbeing Service, we have a motto, see the potential and realise it. So we try and work to that the whole time. We try and see the potential for people and help people to see it for themselves and help them to realise it. We use internal referrals. We work with both acute and enduring pathways. We do a mix of one-to-one and group work. We both work on site here and out there in the community. We offer the Recovery Star. It's not compulsory. You don't have to do the Recovery Star, but most people do it. Opportunities to try and grow and realise their potential. Some of the group work that we do Horizons, which is a drop-in. We've got Beacons Cafe, which is really interesting. Some people might just think it's just a cafe. Actually, it's an opportunity for people to gain work experience. So a lot of the volunteers there, it's actually either part of their care plan, they've chosen this, or they just want to gain pre-work skills or work skills. Some people may be on the Kickstart program with Employment and Social Security. We've had probably about 6 or 7 people come through us and then go on to get jobs. We've offered food hygiene training certificates that people have done through the Institute. Thank you, Institute. They've just let us do the e-learning. We've given that. So our volunteers can come, get work experience with us, gain a qualification, and then go into the workplace. We do art groups. We do health promotion type groups. So we work closely with the health promotion unit. Somebody from there comes over and talks about diet, exercise, healthy eating. We've got a little garden over there. People notice that we've got a garden there? Mm-hmm. Yeah, so we're growing vegetables. We work with Edible Guernsey. I don't know if people have heard of Edible Guernsey and the Men's Sheds project. We use the Decider Skills, which is a very useful DBT-based skills set. We use mindfulness. We weave baskets. We actually weave baskets. The great thing is, in all my years of an occupational therapist, I've never woven a basket. Yet, we had a service user who was working in our workshop, and he was trained in the old traditional Guernsey craft of weaving crab pots. So people used to look at what he was doing and go, well, that looks really interesting. Let's have a go at that. So now he's running groups for us. He's running groups teaching people weaving. Weaving is really good because it helps people concentrate, focus, and it helps with tremor and things like this. So, and people talk and they share ideas, and we do physical health, we do badminton, we go swimming, we do like a Tai Chi yoga type thing that I don't kind of understand, it's all that. We do the RAP document, which is the Wellness Recovery Action Plan, which is putting people back in the driving seat. It's about relapse prevention, getting people to identify what their triggers are, when do they know they're becoming unwell. It's a document that they fill out themselves with the help of us.
What's that called?
It's called the RAP, Wellness Recovery Action Plan, developed in the States, brought over here, we've Guernsey-fied it. It's really, really useful. People find, and we don't keep it. If there's stuff about risk, we talk about, it would be helpful to share that. We go swimming at Beau Séjour. We've got gardening, healthy eating. Again, I'm not going to read through everything. It's on the presentation slides if you want to read it. So we decided to look at the Recovery Star and think, well, is this a reliable, validated tool? So I looked at some of the research out there, and there was some interesting research, 2011, an article published in The Psychiatrist. They looked at 203 working age adults with moderate severe mental health problems from 27 different participating projects, so 27 different areas across the UK. We're using the same tool as us. The Recovery Star was shown to have high internal consistency, appears to measure underlying recovery orientated construct, statistically significant changes in sort of 7 out of 10 areas. So they thought that if there was a slight increase, you know that 1 to 10 thing, they found that generally across the board people would move up, I think it's like 0.87 on average on each increment in 7 out of 10 areas. With us, RAWS, how are we doing, do you think? So we've been running it for about a year and a bit. So let's have a look at how are we doing? I don't know why that's up there. So in February 17, that was our mark. So that's where people first came. And this is an average across the board. So this might be 60 different stars all stuck together. So this is like an average score because it's an electronic tool as well. So we can see incremental changes in every area. In May, just gone, we saw significant changes in each area. That may not look a lot to people, but you don't see huge changes with presentations that are both acute and really enduring for severe mental health issues. But that's quite good. And one of the great things about this tool as well, it makes us think about where we as a service and we as a community can start to improve things. So if we start to see like areas around social networks and things like that we're failing, so what are we not providing? What are we not providing as a community? So it kind of indicates where we can grow, where we can get better. We've started doing KPIs, good old KPIs, which I'm sure everyone's up to date with. And we've got 100% success rate in our KPIs for looking at that standard that we made for ourselves. So what's next? Spinny Men, lots of growth. So how are we going to grow? We're going to continue to use the Recovery Star to guide our service development. So we're going to look at where we're failing, well, not failing, but where we could improve. We want to try and encourage other departments to kind of use the Recovery Star. I know that Community Drug and Alcohol team use the Substance Misuse Star. We know Children's Services have been using it. We know Action for Children have been using it. We're just trying to get more of a groundswell because that common language, people talking the same sort of thing, is really, really useful. And we want to continue to track our performance with our KPIs. Thank you very much. Hands up.
I'm Nikki, I'm one of the midwives and I do some of the training up in our maternity department, and this year we've been doing some training with our midwives and the obstetricians looking at monitoring fetal well-being in labour. Obviously that's listening to the baby's heartbeat is the only way that we can know how the baby's doing in labour. Okay, we have no other record, with no other way of knowing if the baby's happy or distressed apart from just listening to the fetal heartbeat. So it's really important that we do it properly and accurately. And there's two ways to listen to the baby's heartbeat when someone's in labour. We can either use either a Pinard or a sonic aid, and what you do is you actually just hear the baby's heartbeat, you count the beats, and then you also listen to the trends and can tell whether the baby's happy or not. Or we can put a woman on a continuous machine and that continually records the baby's heartbeat and gives us these little traces, and we can tell from those traces whether the baby's happy or not. So there's two ways of doing that. And basically the goal of it all is to make sure that the baby's coping with labour or the baby's getting distressed and we need to deliver the baby earlier. Over the years they've looked at different ways and which of those ways is most accurate. For a long time everybody got put on the CTG, but actually they realised that that wasn't the effective practice, and that actually for low risk women we can just listen in to the baby's heartbeat rather than putting every woman on a machine. So basically, like we just said, they do recommend that for all low risk women that we can just use either a sonic aid or a Pinard to listen to the fetal heart rate. And that if we're doing it correctly that we can pick up if the baby is distressed. But obviously we can hear the heartbeat, but it doesn't mean that what we're actually listening to and then we're actually picking up on any problems. We provide a lot of training to people interpreting the heartbeat traces, and we know that that's not a very effective way of monitoring the baby's heartbeat, and one person can look at a heart rate trace and think that the baby's well, and another person can look at a heart rate trace and actually think the baby's distressed. So it's not an accurate way. And the same with listening to the baby's heartbeat. Sometimes it's difficult to just pick up if the baby's distressed or not. So that's why we decided to do extra training this year. We know that when we've looked through the notes that not all the standards were being met. And we also know of stories, not in Guernsey, but elsewhere that have happened where babies have died through people who've just been listening into the fetal heart but haven't picked up that there's been problems there. So that's why we've decided to focus on it this year in our training. And this basically comes in the reliability part, where we're making sure that we're standardising practice so that for every woman that we look after, they're getting the same standard of practice. So this was our aims. It was to standardise and make sure that everybody was doing the same thing, to make sure that all staff were familiar with the guidelines, that all staff were familiar with the NICE guidelines, and that all staff were able to recognise and respond to any problems, any abnormalities that they were hearing. Then staff would know how to respond to that and would respond. And then we would then have staff that were competent in this area that could then train and make sure other staff were competent. This area we're still working on. That's the ongoing progress part. And it's about when we listen that we're learning, that we're actually making sure that what we're hearing, that the baby is well or not. And that's what we wanted to make sure that everybody was happy, that they could actually analyse that correctly and that we were picking up on any problems. So everybody listened to the training presentation that we did, and then every midwife has been given a competency document to complete. And this competency document is they have to then go and listen to the baby's heartbeat on 3 occasions in the first stage of labour, 3 occasions in the second stage of labour, and another midwife is there assessing that they're doing it properly. And once they've done that, we can then sign off and say that we're happy that they're meeting all the criteria. There's also loads of information in this competency document that they have to read, so that we're making sure that they're reading all the standards as well. And then obviously we can look back on the notes and audit the notes to make sure that people are carrying this out correctly.
Firstly, a lot of the presentations that have gone on in the past, and certainly those today and the Learning Disability Week, all play into what we're trying to do within the transition role. My name is Di Newband. The role of transition coordinator was developed last year. It actually came live on the 1st of April. Don't know whether that's indicative or not. However, my colleague here, Jen, actually used a really good phrase yesterday, which was, I've dug the trench, because the role didn't exist. It came off the back of a Reviewing Children's Services, because it's a massive area, 14 to 21. So the presentation embodies care values principles and Safe for Every Day, and we're hoping that off the back of this we can then move the service forward and broaden it.
Do you want me to do the pointing?
Yeah. Do you want to just introduce yourself and who you are?
No.
This is Jen Bradley. This is our clinical psychologist, who's
I'm your wingman.
my wingman, as I put on the presentation.
Yeah.
When I was interviewed for the post originally as transition coordinator, the actual interview presentation was about developing partnerships, and we all talk about working together and multidisciplinary. The role of transition coordinator starts with school people, schools, families, all sorts of people that are actually alien if you work in an adult world. So that was job number 1. Remains a work in progress, but hopefully after today it will be less of a challenge. The partnerships, again, the role of transition coordinator. I'm a learning disability nurse, but I work with far more people who are not in a healthcare setting. However, people in a healthcare setting play a massive part within the transition process. So the partnerships are about our professional colleagues, as well as the multidisciplinary people from third sector, fourth sector and everywhere else. So again, another challenge. I've made a small step forward, but hopefully after today people will kind of think, oh yeah, I can maybe feed that into Di or my colleagues who I work with.
I think it's very meaningful to have 2 people come up and talk about transition coordinators, because I think the whole idea is that this is what we're trying to sell, that actually we are doing things together. And that point there about it being collaborative and about being open and receptive and talking about attitudes, I think it's about that generosity, if you like, that people actually do try and kind of come together and have an open dialogue with each other and I don't think that I'm alone in saying that often that isn't the case, that people can become quite insular in either in their roles or in their services, in their departments, even in the same team. You know, people can become quite insular in their work. So I think we're not just kind of selling Di's role, but a lot of principles here about people and how they work, and kind of getting past our own egos, I suppose.
Yeah, and again, the job title is that of coordinator, but it's really difficult to coordinate something if people don't actually share and feed in. Because I'm one person with the job title, but there is a whole service out there that we need to make that 14 to 21 journey effective. Because after 21, they become into an adult service and you're faced with way more problems. That information's out there. Let's have it shared, owned equitably, because again, the role of the coordinator's one name that does that job, but actually it's a service-wide. If we get it right at this end, under all the care value principles, which is what I based it on first, principle 6, we've hit the nail on the head. This just endorses it and rubber stamps. You know, 14 to 21, let's get it in there. And hopefully in the future, everybody knows much more about young people with additional needs, and the transitions process is not exclusive to our service. There are many other young people that have got additional disabilities, mental health needs, that are still going to leave home, that still need a house or support or activities. I'm scratching around trying to find day activities for my service users, as it were. But so are you guys. So let's put our heads around the table and say 3 staff next week at the Scout campsite, 20 people got an activity for, rather than me trying to find out, Googling 99 Guernsey charities, only to find the one lady that said, I don't actually do that, I resigned 3 weeks ago or 3 months ago. Yeah, so we've got technology, we've got Google, we've got gov.gg, but actually it's really not as effective as speaking. That's what I've found. I spent 6 months in induction getting nowhere.
Soapbox, Di, you are
Right, okay, sorry. Over to Jen.
Okay. Calm down. So who is part of the transition process? I think, because Di's done these slides, she's put some examples, but essentially, you know, for young people, it's everybody, obviously. It could include the schools, the child and adolescent mental health services, family services, colleges, the wards, hospital units, everybody, essentially. And I think what we're trying to say is to not kind of take that for granted. The whole point of the transition and then the coordination bit, again, is about don't take for granted that everybody's there who needs to be there. So be asking those questions about, is everybody here who needs to be? I mean, I can't count the number of times I've gone into meetings and then later realised that there's another team of people involved somewhere else, and nobody's kind of thought to mention that. So I suppose this is a kind of point to say who is actually going to be a key part of this transition process.
Which fits in really nicely if we use that single care plan approach. It's never too early to start. It can only get bigger, but if we've got bigger databases, we just all feed it in.
So we need to be thinking about, well, all of these things, but essentially the theme of all of these bullet points is about communication, I would say.
It is, and I wrote a comment, and it really isn't meant to sound emotive or anything else, but there is lots of research and everything else that talks about email abdication, and I've kind of been on the receiving end of that with colleagues in different departments, because they have different roles and everything else, which I don't fully understand because I don't work in their services. So it gets sent and that's their bit done. I've done it myself, so I'm not saying, you know, anything. It's very easy to send an email and think I've done my bit, but when you're actually around the table and you've got families, because there's a lot of parents and carers and foster carers and other service leads, they all know their bit, and they sent me, again, one person an email. So we really need to kind of perhaps look at how many times we spend deleting emails and replying, as opposed to 1 hour of our time spent conducively round a table, probably do away with half a day's worth of Curt Alt delete, or forward to all, so all the service has got an email that they don't know.
That's a principle in psychology, where we know that people don't do things. If you send out a large email to lots of different people, we know that the chances of there being some action on the back of that is vastly reduced, because everybody sees who else is copied into it, ergo you think somebody else is going to take care of it. Actually, when you do just sit down face to face with people who are accountable because they're physically there and you can see them like we can see each other right now, I can say to you, okay, so what's the plan and who's going to do what? And that's a key part of this, just trying to keep it nice and simple, but actually talking face to face, having conversations and having a plan that then people are held accountable, which is one of the words there, and comes under teamwork and negotiation. And I can't think that it doesn't tap into all of these, that process of coordinating the transition is about us being sensible and being grown-ups and not just sitting behind the emails.
And it's about actually understanding and appreciating that the so-called land of milk and honey in children's services is actually equitable to the services in adult. There is a statutory entitlement for children and young people which is there to maximise opportunity and learning and everything else. But we can share that because we can work together to manage expectations and resources, because if they're investing heavily at that end and we're getting it wrong at our end, we're just kind of throwing all our expertise and time kind of away. So just off the back of the other week, there was the Learning Disability Week, which lots of my colleagues were involved in, and I understand it went really well. But death by indifference, diagnostic overshadowing, discrimination, value judgment, secondary care and prejudice in settings are nationally things that have been cited as fundamental barriers to successful transitions. We've got a blank canvas in Guernsey because that role's never really been established. So those are the things that end up in the newspaper that make massive headlines. If we look at the developing embed services, again, all the presentations that I've been to talk about partnership, working and talking. Not having it based in the hospital, because people think, oh, I can't be a nurse because I don't work in the hospital. It's fine. Well, what do you know about children's services? Because they're different. Well, actually, none of us are different because we've all vested in our professional qualifications or other qualifications within a particular healthcare role. So these are the things that will emerge if we don't. And in Guernsey, we've got a massive opportunity to have an absolutely stellar transition service just by other people making themselves known and saying, do you know what, in my department we really have one heck of a problem with that, but together we might be able to sort it. Basically, it's the standout journey.
I don't know what to put myself.
We're just
we just say we start
music?
dancing.
Yeah, we talk about, I go back to the care principles because that's something that was kind of in place before this, and the transition journey is kind of a winner because it's got that at its day-to-day working across all the service, and it's out there in the public domain about treating people equitably, and then we've got the rubber stamp. So if we're not quite there, we can take it from there. If we're not hitting that, we can go back to that. So nobody should feel uncomfortable and think, I'm not a learning disability nurse. I'm not in the adult disability. I don't understand what they do in schools. Because believe me, do you know what Key Stage 5 is? Doing well in Key Stage 5. I'm not knocking my colleagues in children's services. But at a review, a phrase like that means different things to different people, and we need to all understand what Key Stage 5 is to move that young person along their transition journey. And that's just really sums everything up. James very kindly did our nice pictures there. But it would be fair to say my first 6 months of the role, I might as well have just been floundering, because I tried every different angle to put myself out there. But I realised, one, I only work 37.5 hours a week. Two, although Guernsey is small, there are so many people out there. And hopefully after today, at least the role of transition coordinator will sort of be remembered by a few of you, or you'll pass it on to your colleagues and feed back into the system. The person doing the job is me, but the role is held by the team and the service. So anybody who wants to email anything into anybody, we're all wanting more activities, we're all wanting more care, we're all wanting more staff. Graham's presentation on mental health, 90% of what he talked about is exactly the same as what we're trying to do with our clients, our vulnerable people, our people with a different needs, young people, people with a physical disability. It's not restricted really to learning disabilities, although that's where the role's held. Because all of you will be thinking, what am I doing with this young person? I don't know where to send them. Well, there's a wealth of expertise across the service. We just all need to join ourselves together. Is that it?
Is it worth mentioning what?
I don't know.
That's fine.
I don't know.
We'll just go
Mention what?
where-
Go back now.
No, I was just going to say, is it worth mentioning kind of what next? Because we need to leave on a high note.
I was going to say, what next? Well, no, I think it's, what next is, even if one person emails back to us and says, do you know what, I've got a group of young people that we're struggling on, what can we share? Can we just produce something generic? Because you must have the same problems thinking about, do you know anything about benefits, housing? Parents need a lot of reassurance. You might have some tips, we might have some tips. It's just, I think today hopefully is just, as Jen said the other day, we've dug the trench. Hopefully you guys can give us the rest of the building bricks to take this forward in the next sort of 6 to 12 months and beyond.